and welcome to the Ohio Crisis Academy on Rural Crisis Response. My name is Alicia Clark, and I am the Assistant Director of Community Planning and Collaboration at the Ohio Department of Mental Health and Addiction Services, and I'm glad you could join us. I wanted to go over a few items before going to the training and starting this morning. So a few housekeeping items. We are using the Zoom webinar today, which means that attendees cannot use their microphones or videos. We will not be able to see or hear you. The chat function is also disabled for you today. While the panelists and I can send you information through the chat, you will not be able to respond. If you have a question that pops up as you're listening to our exciting presenters, feel free to add that question to the question and answer box. At the end of each presentation, I will pose some of these questions to our presenters. So keep your questions related to the content and the topics we're learning about today. If you have any technical difficulties throughout this training, please contact Courtney Ebersol. She will be posting her email in the chat box for your convenience. For continuing education credit, this training has been approved for 2.75 continuing education hours for the following disciplines: nurses, social workers, mental health counselors, prevention professionals, chemical dependency counselors, and psychologists. By logging onto the training, we will be able to track your attendance. If you log out early, we will adjust your certificate to the amount of time in which you participated. Please note that you must have registered for the training in order for us to track your attendance and award your CE credit. Using someone else's Zoom information to log on will result in you appearing under that individual's name, and we will not be able to verify your attendance. Please note that we are also unable to confirm attendance for those who dialed in by phone to join the webinar. After the training, Courtney Ebersol will send an email that includes a SurveyMonkey link that will allow you to participate to evaluate the training. You must complete the evaluation in order to receive the CE credit. Please ensure that you've provided your license number in the evaluation. After completing your evaluation through SurveyMonkey, your CE certificate will be emailed to you within 2 weeks. Courtney will be sending you a brief post-event survey for the Great Lakes Mental Health Technology Transfer Center, one of today's training sponsors. We will appreciate if you take a moment to complete this evaluation. And now we'll get started with our program. I have the pleasure of introducing my boss, the Director of the Ohio Department of Mental Health and Addiction Services, Lori Chris. Director Chris is a native of Eastern Ohio. She began engaging in the behavioral health field in 1992. Her experience includes working for the Ohio Commission on Minority Health and Amethyst prior to coming to the Department of Mental Health and Addiction Services. Lori also served as the Chief Executive Officer of the Ohio Council of Behavioral Health and Family Service Providers. Director Chris holds a bachelor's and master's degree in social work from The Ohio State University. She graduated from SAMHSA's 2010-2011 Women of Addiction Services Leadership Institute, a year-long nationally selective intensive program built to design leaders for the nation's behavioral health field. Director Chris has most recently served on the advisory board to the Ohio Criminal Sentencing Commission, the National Council for Behavioral Health Addiction Policy Committee, and Ohio's Housing and Homelessness Collaborative. She is a former board member for the National Alliance for Recovery Residences and serves as the principal advisor for Ohio Recovery, used to serve as the principal advisor for Ohio Recovery Housing. I'd like to introduce Director Lori Chris.
Thank you so much, Alicia. And I want to thank OACBHA for organizing this session and planning it, and along with the entire planning committee and all of the sponsors. It's just wonderful that we're able to come together for this kind of learning and make it so accessible and available. It's great to see so many people participating. We're over 250 participants now, which is wonderful. And, it's important that we're talking about crisis services in Ohio because they're so necessary to meet the needs of Ohio's youth and adults and families and really help men and women and youth with mental health and substance use disorders who are experiencing crisis with these avoid arrest or incarceration, avoid long-term homelessness or unnecessary hospitalizations, or mistreatment altogether and be misdiagnosed or not have access to treatment, or even have premature death because of these illnesses. It's all unnecessary, and crisis services play a big role in helping to avoid these consequences. We've been working hard together as a community of practitioners here in Ohio to build a full continuum of care for crisis services. And when I look at what's been accomplished in recent years, it's astounding. We have CIT trained officers in every county. We have hotlines and call centers in every county. We now have 68 crisis stabilization centers around the state, and we have detox and inpatient services, mobile crisis and peer crisis response in nearly every county in the state. But we have so much more to do. We have to make sure that we have all of this full continuum of crisis response and support available for every age across the state and every community, and that people know and have visible on-ramps to these crisis services and supports, and have accessibility not just to those mobile response and stabilization units, but also then to those transitions to care that will help people sustain that stability and high quality of life in the community on an ongoing basis to avoid crisis in the future. So we know that the design and services of services and our planning and response looks different in every single part of our state, and that we can't just pick one model that will work in every single community. And that's been a big part of these crisis academies and these sessions, to make sure that we're learning from the experts around the country, the experts within our state who are pursuing evidence-based practices and receiving and seeing good outcomes with what they're offering in their local communities. And today's session is vitally important for our collective learning and for our planning for rural communities. We know that 56% of counties in Ohio and 25% of Ohio's population live in rural counties. And so we have a strong commitment to making sure that the design and the opportunities and the resources and investments are available to every single community, every single youth, every single adult who needs these crisis services, and that we can support providers in implementing these, and boards and planning for these, families and accessing these. And so we're excited to be here today, looking forward to learning from all of the panelists that will be sharing with us. So thank you, have a great session, and I'm looking forward to learning alongside.
Thanks, Director Chris. Good morning. My name is Sherry Walter, and I'm the CEO of the Ohio Association of County Behavioral Health Authorities. I really do want to start by thanking Director Chris and the Department of Mental Health and Addiction Services. They're really the folks that have taken a focus on crisis, and this is now our 5th Crisis Academy, and they have been supporting having these crisis academies since the get-go, and it really was Director Chris's vision. So thank you for that, because I think we're really beginning to learn a lot about what's happening in Ohio. This morning, as we're talking about behavioral health services and crisis services in the rural community, I'm very excited to introduce our next speaker. Dr. Ron Manderscheid serves as the Executive Director of the National Association for Rural Mental Health. Concurrently, he's also the Executive Director of the National Association of County Behavioral Health and Developmental Disabilities Directors. He's also an adjunct professor at the Department of Mental Health for the Bloomberg School of Public Health at Johns Hopkins University, and the adjunct professor for the School of Social Work at the University of Southern California. Dr. Manderscheid serves on the boards of the Cosmos Clubs, the Employee Assistance Research Foundation, and the Dynia Institute, the Council on Quality and Leadership, the National Association of State Mental Health Program Research Institute, and the National Register of Health Services Psychologists. He also serves as the co-chair of the Coalition of Whole Health. He's also has served as the SRA International and in several federal leadership roles at the U.S. Department of Health and Human Services. I've known Ron now for the last 20 years. I've been in my job, and frankly, you're not going to find somebody who knows more about what's going on across the country in behavioral health. And so I'm really looking forward to hearing Dr. Manderscheid. And with that, Ron, I'm going to turn it over to you. And thank you for coming today.
Yeah. Thank you very much, Sherry. I'm always delighted to come and work with my good friends and colleagues from Ohio. So let me start sharing my screen here. And I want to make a note that if you're going to record this, I don't believe it's being recorded right now. So you may want to turn on recording. So I want to begin with the quote from Amanda Gorman, who was the Youth Poet Laureate of the United States, who spoke at the recent inauguration of President Biden. And this is the last phrase that she used in her talk, which I think is very telling for us in behavioral health. The new dawn blooms as we free it, for there is always light. If only we're brave enough to see it, if only we're brave enough to be it. So I think this applies very much to us in behavioral health care, because our whole world is changing very rapidly, and I'll talk about that in a few minutes here. I also want to bring you greetings and best wishes from our organization. So from the 2,000 county behavioral health directors in the United States, our 500 colleagues in the National Association for Rural Mental Health, and our 275 national organizations that now belong to the Coalition for Whole Health. So if you're not a member of one of our organizations, I encourage you to do that. And the Coalition for Whole Health is totally free. We have a call every single month. All you have to do is send me an email and we'll sign you up for that. So moving ahead here, where we're going to go, I want to start by putting a context around behavioral health care, where it is currently, how COVID has affected it. And then I'm going to bring in a different perspective on crisis response. I'm going to bring in a population health perspective on that, which I hope will be very useful for the conversation. I want to talk a little bit about building communities and actually building a community crisis response system. So obviously, behavioral health conditions are pervasive, and you all know that. 25% of adults and 20% of children have a diagnosable behavioral health condition in each year. That's an annual prevalence figure. 6% of adults and 9 to 13% of adolescents have serious and persistent mental health conditions. That's the population that the public sector deals with all the time. More than 11% of those aged 12 and older use illicit drugs, and more than 2% use prescription drugs for non-medical purposes. And these numbers have gone through the roof in the COVID period. Drug overdose deaths are approaching 80,000 per year. 50,000 persons die each year by suicide, and about 8.5 million persons have co-occurring mental health and substance use conditions. So we just have a very, very pervasive problem. Obviously, behavioral health can't meet the current demand. So no more than half of adults and a quarter of children and adolescents with behavioral health conditions receive any care at all. So the other half of the adults and the other 3/4 of children and adolescents with these problems never are seen by a behavioral health person, never are seen for behavioral health conditions by a primary care provider. They're never seen in the social service system for this, and they receive no self-help. Only about 20% of those adults receive care from a behavioral health provider. 80% receive care from primary care providers. So what's changed in the years that I've been in this field, when I first started in this field at NIMH a long time ago, the bulk of people who received behavioral health care received it from a specialist. Now the bulk of people who receive behavioral health care receive it from a primary care physician, which leads us into a whole discussion which we could have about integrated care and the evolution of integrated care. Many who do not receive care are homeless or incarcerated in city and county jails. So this is an area we're working on in NACBID and have been for quite a while. And we know several things. We know tonight there are going to be 730,000 people in the city and county jails of the US. 80% of those people will be people who have a primary mental health or substance use condition. And a new group in that population are probably 5 to 10% of people who also have an intellectual or developmental disability. What's happening in that population is youth who are graduating out from youth programs are not being picked up in adult programs. They become homeless. They become incarcerated. So we also know about the epidemiology of incarceration. If you have a mental illness, you're at great risk of becoming homeless. If you become homeless, you're at great risk of becoming incarcerated. So a very serious issue. The behavioral health field suffers from a severe human resource crisis currently. I developed a national strategic plan for human resources when I was in SAMHSA 15 years ago. And at that time, I would have described it as a problem. That problem has continued to develop, and I would describe it as a very serious crisis at the present time. Our baby boomers are retiring. These are the people who ran the system for years. We then have a baby bust generation where people did not come into behavioral health. Then we have, I'm going to say, a 45 and under group who are emerging as the new leaders, and we have the millennials. The millennials only stay in a position for 2 or 3 years and then they move on. They aren't able to actually develop a foothold and develop a career path, which is very problematic for us because if we're not able to develop career paths for them, they will probably ultimately leave us. More reliance is being placed on peer supporters, virtual care, and self-care these days. Peer supporters, we could have a big conversation about the role of peer supporters in mitigating crises, and they played a big role in this as we've moved into the COVID period. Behavioral health care has been very slow to adopt integrated care approaches. So ever since we've had the Affordable Care Act in 2010, there's been legislation and federal policy to move the field toward integrated care. That has been very slow in coming in the last 10 years. I think virtual care has facilitated a more rapid movement toward that, and we can talk about that as well. Now I'm going to shift gears here. Things are really changing for us. I want to talk about COVID. So COVID and behavioral health. COVID-19 and its mitigating strategies are generating a behavioral health pandemic. So we have the oddity that we are having a pandemic within a pandemic, and I'm sure you're seeing that in Ohio as well. And the most recent data that I could find are a CDC, Centers for Disease Control survey conducted in June 2020. And that survey covers the period from about March 15th to June 15th. And these were the findings. So in that survey, 41% of adults, 41% had at least one mental or behavioral health consequence as a result of COVID or its mitigation strategies. And by mitigation strategies, I mean things like not leaving your house, having your children at home with you all the time, not being able to see your family members, not being able to interact with your elderly parents or grandparents, and so on. Those are the mitigation type factors. 31% had anxiety or depression, 26% trauma or stress. So if I take those numbers and look at the classic numbers are the numbers I gave you a few minutes ago. We are basically doubling our behavioral health problem here. 13% increased substance abuse, 11% contemplating suicide in a 3-month period. Even more concerning, 33% of unpaid caregivers contemplated suicide. That's just an incredible number. 25% of those 18 to 24 contemplated suicide. Tremendous, it's amazing, it's an amazing number. 22% of essential health workers contemplated suicide. What if we actually lost, even if it wasn't 22%, what if 5% of the essential health workers actually committed suicide? Where would we be in our first responders and our responders who are caring for people in hospitals? All of these rates are expected to grow even further over the next 12 months. And we don't know what the ceiling is because we've never encountered this type of crisis before. So in 9/11 and in Katrina, we saw a secondary behavioral health effect where it grew for 12 to 18 months after the event. I guess we need to expect that that will continue for us. We just don't know what the ceiling will be for this. Thus, we're on the cusp of a behavioral health pandemic. Behavioral health care itself has also changed dramatically. And I'm going to put it in 1 month. In April 2020, behavioral health care transitioned from interpersonal care to virtual. So something happened in a 30-day period that probably would have taken 3 to 5 years had we never had the COVID pandemic, basically. And there were a lot of important learnings from this. There were learnings about how we do this from people's home. There were learnings about computer systems and how people working from home may not have access, excuse me, to electronic health records from their office, et cetera, et cetera, et cetera. People learning to do this online who had never been online before. Many, many learnings. But I think we did as a field, and we should congratulate ourselves, doing a tremendous job to move virtual care in that 1 month period. Now, for the virtual care itself, worked better for some people. So we actually found some people doing better. And if you think about that, what virtual care does, it puts the consumer on par with the provider. In interpersonal care, typically the consumer has to go to the office of the provider, and that puts the provider in the upper hand. In virtual care, that isn't the case. In virtual care, if the consumer doesn't like it, they can turn the system off, basically. So I think so in a certain sense, virtual care has been empowering to a lot of our consumers. There's another group of consumers at the more serious end of the continuum who've done worse with virtual care because they really need the interpersonal contact every single day. And just as with your family members, that's been pretty much prevented from happening because of COVID and the risk of super spreader events and so on. And there have been some strategies developed to address that. For example, peers reaching out and being in contact with primary consumers literally every day of the week and so on. So there are strategies for dealing with that, but they aren't perfect strategies. We need to do better for that particular group. Behavioral health care had great difficulty acquiring PPE. So our providers who work in hospitals or work in residential care centers in many communities weren't able to get PPE initially because they weren't considered essential health workers. That's a tragedy. And if that exists in Ohio or exists in counties in Ohio, that needs to be changed, basically. Because a lot of some of my students at USC are these providers working in these facilities. They were literally scared to go to work for fear they would get COVID and they would bring it home to their children or their spouses and so on. So we need to do better in that dimension for our providers. Mental hospitals and local jails deinstitutionalized rapidly, leading to problems in local communities. So what the hospitals and jails did is they closed the front door and they said, well, you don't want to become super spreaders here. We're going to close the front door and we're going to release people early, which they did. But all of this happened without appropriate planning with the local communities. So many local communities were flooded with people coming out of these facilities, people who were at high risk of being homeless, had no links to services, had no links to care coordination, and so on. In the early part of this period, in April and May, revenue of behavioral health organizations fell 40 to 50% and has recovered only partially. I would say we're back up probably to 85 to 90% of the income we had before through several things. We learned how to do virtual care much more effectively. CMS made adjustments in pay for virtual care in Medicaid and Medicare. We were able to use telephonic care and so on. And if you become efficient at that, you can do an awful lot of virtual care in a day, basically. So we've been able to recover income, but I don't think we're fully back yet. Important gains were made in expanding virtual behavioral health care, may be limited unless permanent extensions can be achieved through federal Medicare and Medicaid. And we're obviously now at the national level working very closely with the Biden administration and with the Hill to try to make that happen for both Medicaid and Medicare. The estimated financial shortfall in behavioral care is about $38 billion, and overall in the states, about $500 billion, in the counties, $150 billion. If we are not able to get some of that $500 billion and $150 billion in the new Biden-Harris plan, I think many states are going to have to cut their budgets going forward 20 to 30%. And there's no reason to believe that behavioral health would not be cut the same way other state operations would be cut here. So we got to keep our fingers crossed that the Biden-Harris American Rescue Plan actually will pass close to the $1.9 trillion level. And I think it has about $350 billion of that $650 billion that we're looking at here. Future of behavioral health care is uncertain at present. So what can be done? The current crisis in behavioral health care can be partially mitigated through implementing population behavioral health care. Prevention is always preferred over treatment. Such changes also will mitigate behavioral health crises in the community. So now I want to go on and talk a little bit about population behavioral health. And so I think, like integrated care, population behavioral care has come only slowly to behavioral health care. And that's because I think most of our people in the field don't have much training in public health. And to really get into population behavioral care, you've got to engage some of our colleagues who work in public health. And, you know, something like 1,750 of our 2,900 counties in the United States do have public health workers. And we need to be working much more closely with them, and we need to be training some of our own people jointly. For example, I now have students coming to me who want to get training jointly in social work and in public health. And there are very few programs that actually do that currently. So the underlying model here is that the negative social and physical determinants of health lead to personal and family trauma, lead to health and behavioral health consequences, and need for care and support. That's the classic model that we're working against. So if you're going to change that model, where do you start? You start up at the top with negative social and physical determinants of health. Trauma causes about 85% of all behavioral health conditions. A good example is the ACEs, childhood ACEs, a classic study done in Kaiser Permanente of Southern California about 20 years ago, and found that many young adults who had behavioral health conditions had numerous adverse childhood experience, all types of trauma, sexual trauma, abuse, violence, seeing shootings in their own neighborhood. Many children who go to school these days actually have seen somebody shot, but these types of things. So people who experienced those adverse childhood experiences, then by the time they became adults, 18 to 20, had like a 95% chance of developing a behavioral health condition. So we've been trying to develop trauma-informed care and trauma-informed recovery to address that. And yes, we need to do that, but also we need to go upstream and ask, what can we do to reduce adverse childhood experiences? We now recognize that persons in behavioral health care field also would need training in public health and community interventions. Joint degrees are becoming more common, as I said here. So the question, can we use population behavioral care strategies to prevent and reduce the behavioral health and social effects of COVID-19 and its mitigation efforts? And can we use population behavioral care strategies to prevent and reduce behavioral health crises that occur in the community? So my argument, population behavioral care will change communities. And I'm kind of walk through this. In population behavioral care, the essence of disease prevention, health promotion is changing community level, negative social and physical determinants of health and implementing positive ones. To do this, we will need to deconstruct these determinants, identify their origins, and modify these origins. Thus, we can bring change to communities that will result in population level change for all who are exposed to these determinants. So there's two ideas here, that we have determinants out in the communities, first idea, and the second idea is these determinants affect different people in the community differently depending on their exposure. For example, in a typical community, most people are not exposed to adverse housing conditions. Some people are. Some people actually have rats living in their houses. That's a differential exposure to a social and physical determinant of health. Same way with violence. Some people are exposed to violence, other people are not. So again, the two ideas, we've got these social and physical determinants of health, and secondly, they influence different people differently. The negative social and physical determinants of health range from very simple to very complex, from rats in a house to poor quality education or poverty. Positive social and physical determinants of health also range from simple to complex, from good quality housing to a supportive environment that promotes resilience. We will need to develop the capacity to address the full range of these determinants. And I think that work is going to fall largely on people in the behavioral health system. So we come to do this. To do this, public health strategies directed at changing community social and physical health determinants will need to be linked to population health management strategies directed at subsets of people who have similar exposure to these determinants. So that again, the two ideas, the social and physical determinants of health influence different subgroups differently. We will need to pay attention to that and subaggregate the population in our work at this level. A key part of this work will involve extensive collaboration that expands public health, behavioral health, population health management, and healthcare. Thus, population behavioral care has a key role to play in preventing and reducing behavioral health crises that occur in the community. So I'm going to go through a little bit more here. It says, you've got a rare condition called good health. Frankly, we don't know how to treat that. So I want to show you a few things. So literally 40 years ago, we had the thought that disease and wellness or disease and health are not two ends of the same continuum. They are two continua, which is what you see here. You see a disease continuum and this a well-being continuum here. So as soon as you think of these things as two continua rather than one, you generate possibilities. So this immediately generates the possibility here that I can subaggregate the people on these continua into four population groups. You see population 1, 2, 3, and 4. Obviously, where you want to be is the upper left-hand corner, population 1, people with no disease, very good well-being. The people we typically deal with in behavioral health are in population 4. They have fairly severe disease and most have very poor well-being. So this model is the underlying model of implementing a population health strategy. And in most population health strategy models, there would be no more than 8 subpopulation groups. So instead of 1, 2, 3, and 4, I could have 1A, 1B, 2A, 2B, 3A, 3B, and 4A, 4B. That would be a classic population health management strategy. So what I've done here is say, well, how do we actually implement this currently in behavioral health? So you see the disease dimension is the horizontal dimension and the wellness dimension is the vertical dimension. So if you stay in the horizontal dimension, and you're starting the lower right-hand quadrant, high morbidity and mortality, you're going to be working in classic biopsychosocial interventions. You're going to be giving people drugs. You're going to be working with them in various forms of verbal therapy and so on, but you're going to be basically in that dimension. If you want to add the second dimension, you're going to have to move vertically. You're going to have to get into self-help, social support, changes in unhealthy lifestyle, and so on. You're going to have to get into the social and physical determinants of health. And in order to move someone from the lower right-hand quadrant to the upper left-hand quadrant, you're going to have to work both dimensions, basically. So traditionally, we've worked the horizontal dimension. We are now getting into working the vertical dimension here. So the two dimensions, well-being and illness, and what we're adding, because we've learned about this, we're adding the third dimension, community. So envision not the four-celled matrix I've showed you before, but a cube that would have a third dimension that are community factors where people are exposed or not exposed to particular social and physical determinants of health. So population health management can partition populations into different levels of exposure to specific social and physical determinants of health and into different levels of propensity to experience crises. And I guess I don't believe pretty much in the field we are doing the latter in behavioral health yet. So I'm advocating that we think about this and we begin figuring out ways to do this. Thus, population behavioral care can modify these determinants, their antecedents, and their consequences. And for purposes of this morning, what we would want to be doing, we would want to be modifying the social and physical determinants of health to make it less likely that someone will go into a behavioral health crisis. And we're going to have to subaggregate the people who are likely to experience behavioral health crises depending on the types of social and physical determinants of health they're exposed to, which could range all the way from, this person is in a social situation that's very dysfunctional. What do we do about that? How do we prevent that dysfunctionality from turning into a crisis? Or this person is another, even more likely, this person is totally socially isolated. When I was working with Ron Kessler on the National Comorbidity Survey, we actually had one respondent who said, when asked, how long has it been since you've talked to anyone? The person said, I haven't talked to anybody for 7 months. Just imagine that, not having talked to anybody for 7 months. And the social isolation and loneliness and so on, another huge social and physical determinant of health that I think affects a lot of our people, is another precipitating factor for crises for people. And there are many. I could just go on and on and on talking about these. A similar approach can be used to address systemic racism. And I put this into the talk because I just want to do a couple of overheads on that as well. So systemic racism is baked into our basic community institutions: education, economy, religion, family, healthcare. As a result, minority persons experience trauma through these institutions via negative social and physical determinants of health. Thus, in the extreme, these minority persons will develop adverse health and behavioral health conditions as a result of exposure to these determinants, in some cases, even death. And there's a certain propensity, if you have been discriminated against your whole life, the probability of you dying early goes up somewhere between 5 and 10%. So your probability of dying earlier will be 5 to 10% higher than other people, simply because you were exposed to this discrimination. What are the sources of these systemic racism determinants? Power dynamics in our institutions: status power, economic power, political power, personal power, knowledge power, all types of power. The solution will need to involve organizing, engaging, and changing these power dynamics. And I put a little example of community schools here. So if I look at the schools of some of our cities here, Baltimore and DC as good examples. In Baltimore and DC, we are losing about 35% of people as they go through high school. So 35% of people who start high school never complete it. Most of those people are minorities. So then the issue is, why are most of the people who actually are not making it through the system minorities? has to do with the power dynamics, including the power dynamics in our schools. And we could have a long conversation about that. Key partnerships will need to be built among businesses, not-for-profit entities, and government agencies that change the power dynamics in our institutions that support systemic racism and its effects. And the previous Surgeon General Adams, actually did a Surgeon General's report on how businesses, not-for-profit entities, and government agencies could work together to mitigate some of these effects in communities. So if you haven't seen that, I would encourage you to look at that. Once the power dynamics have been changed in public health, population behavioral health, population health management, and healthcare can modify the relevant social and physical determinants of health that result from systemic racism. Now I want to transition and talk just briefly, a few minutes, about building communities and then about crisis response systems. So building communities is an important tool to prevent and reduce community behavioral health crises. And one of the things I'm involved in right now is a rural behavioral health collaborative, excuse me, that we've created in an entity called the International Initiative on Mental Health Leadership. And the International Initiative on Mental Health Leadership represents all of the English-speaking countries in the world. So the US, the UK, Canada, Australia, New Zealand, and even some of the countries that where English is not the primary, like Sweden, Denmark, Norway, and so on. Anyone can belong to the International Initiative on Mental Health Leadership. All you have to do is sign up. There is no cost to belonging because the dues are paid by your country. So the United States pays the dues for people from the United States who belong to the International Initiative on Mental Health Leadership. So I would encourage you to consider that. So what we're doing in the Rural Behavioral Health Collaborative, which is a new collaborative now about 1 year old, is trying to understand how communities can be organized and self-organized to address community problems, including behavioral health crises. So what we're doing in our meetings right now, we're outreaching to different places to actually speak with community members who are working on these problems. And our first outreach was to 5 Texas counties, 5 rural Texas counties that are being funded by the Hogg Foundation. And you all know that the Hogg Foundation is a foundation that funds projects in Texas because it's a Texas-based group. And we're planning additional outreach. I think our next one is going to be Canada. We're going to probably have that meeting in May, and then about every 2 months thereafter, we'll do Netherlands, Australia, and New Zealand. We've got those lined up. And obviously our goal here is to learn the best practices, and I'm going to call these practice-based evidence, not evidence-based practice, but practice-based evidence. What are these communities actually doing to address some of these issues? And how can we take that and transport it from a rural county in Texas to a rural county in New Zealand, basically, underlying idea. What are some of our learnings from the Texas counties? I think foundational here is the fact that, and the 3 things I've written here were actually said by one of the speakers, always listen to your community. Don't come assuming that you have the solution. Listen to what the community members are telling you about the problem, its origins, what can be done about it, and so on. Redefine inclusivity, and that was specifically mentioned virtually by all of the counties, meaning that we have to bring into the conversation what are called historically excluded groups, Blacks, in Texas, Hispanics, American Indian groups, et cetera, people who've been excluded for decades and centuries from the conversation. And then we're going to need to get kind of to the 3rd stage here, get things done through relationships and interactions. And I'll cite an example of that. So in one of the counties, two of the people working on the project actually said, you know, one of our serious problems here is homelessness and how we treat the problem of homelessness here. We need to talk to people who are homeless. So they started going to a site where homeless people came every day for dinner, and they ate dinner with the homeless people. Over time, they got accepted into the group, and then they engaged in conversations with those homeless people. And in those conversations, they developed a much better understanding of some of the problems these homeless people faced, and were then able to actually go back into the institutional structure of the government and the 501c3s in the community and do something about it. So that's a good example of getting things done through relationships and interactions. Moving from an approach based upon traditional coalitions to one based upon networks. And first, when I heard this, well, I said, you know, why would you be doing that? And I thought about it, and I said, well, you know, traditional coalitions simply reinforce the power structure that exists in a community, because you start with the groups that are there. You don't create nascent groups. Networks allow the creation of nascent groups. So if your model is not a coalition model, but your model is a network model, you can probably bring about more change in a community than the reverse. And then finally, once networks are developed, shared leadership can begin to emerge. And this was described by one of the participants as leaderful groups that, you know, when you initially start doing something, not many people are going to run forth to the front of the room saying, oh, well, you know, I want to be involved and I want to lead this process and so on. If you use this network approach where you develop confidence, you include people who've not been included before, your leaders in the process will be very bountiful, in the sense that many people will step forward and say they want to be part of the process. They'd like to lead part X or A or C or whatever. It just changes the nature of how you do this. So we are very impressed with this work, and we're going to continue pursuing it. Now, let me say a little bit about building community crisis response systems. So, and the work that's been done in this area, and we ourselves have done a little work in this area because of our decarceration initiative. So let me spend just a minute saying a word about our decarceration initiative. So in NACBID, we've been working on decarceration for 5 years. So first year, what we did is we went out and we ran focus groups of medium-sized and small counties to learn what they were doing about the problem of incarceration of people with behavioral health and intellectual and developmental disability conditions, and what their problems were, how they were organizing this, and so on. And what we came away with is that the medium-sized counties are very different than the small counties. Medium-sized counties all were doing something, maybe not always the most effectively, but they were doing things. The little rural counties were literally not doing anything, even though they knew they had a problem. They had no behavioral health capacity to do anything. They had no leadership capacity, and so on. And the very large counties like Cook County, Illinois, or LA County, or New York County in New York, had their own capacity. So what we decided to focus on were the medium-sized counties and the small counties. So in year 2, we did technical assistance. And we did big technical assistance webinars where we would have 200-300 people on a webinar, and we would talk about the sequential intercept model. And at that time, the sequential intercept model had 1 to 5 intercepts. Intercept 1 is when you first encounter the police, to intercept 5 and when we get you out of jail because we've had a court action of some type. And we said, well, there ought to be an intercept 0, and intercept 0 is, the best intercept is never encountering the police in the first place. How do you bring that about? So we did TA on this. We did TA on organizing work groups. We worked with the National Association of Counties on their Stepping Up initiative and so on. Third year, we actually did a pilot with about 25 counties they were from New Mexico, Kansas, Iowa, Missouri, Michigan, and New York. And we picked those particular states and counties because they represented a lot of difference in diversity. They represented difference in terms of participation in the Medicaid expansion of the Affordable Care Act and so on. And then we worked with them literally every month for a year. And if you wanted to participate, you had to bring both sides of the equation. You had to bring not only the health segment out of your county behavioral health or your county health or your county social services, you also had to bring the criminal justice side. You had to bring the sheriff's office, the local police department, you had to bring your county correctional officer if you had one. Everybody had to be at the table, and there had to be some leadership from the county board. There had to be somebody from the county board who participated or at least was represented in the process. And we were able in that to fast forward this to move medium-sized counties along, I think, in a fairly good way, those that participated. We were not able to move little rural counties. Just didn't work. We were batting our head against a wall here. And so we said we need a new strategy for these little rural counties. So in the next year, we actually undertook a pilot, and we did it in Kansas. We said, in order to move those little rural counties, we have to engage much more effectively the state government, and we have to engage the state associations. So NACBID hosted a meeting out in Topeka. We had the governor there. We had the state health commissioner, the state Medicaid commissioner. We had the two leads from the Senate and House in the Kansas Senate and House. We had the behavioral health people. We had some consumers and peers there. And we talked about this. And out of this came a strategy to create rural crisis response centers in Kansas, and also a commitment to ultimately do the Medicaid expansion in Kansas. And the governor was very supportive of this. So after we had the meeting, the people from the legislature actually took this back to the legislature and created bills to do both of these things. And the bill to create the rural crisis response centers has been passed, and money has been appropriated to do that. And the Medicaid expansion, there was support for that in both the Senate and House. Somebody on one of the committees in, I don't know which house it was, put a poison pill into the bill, put abortion into the bill. And as soon as you did that, then that killed it. And so now they're starting over again. So we were at least hopefully 50% successful in what we were doing with them. So our work in this area leads to the couple overheads I'm going to show you here. That really, if you're going to do a community crisis response system, you have to have 3 levels, and you have to have capacity for virtual inreach so people can call in, and you have to have capacity for virtual outreach. You can outreach to people who need to have outreach. And that has to involve various levels and gradations, from a warm line, perhaps run by peers, to a hotline, and may be integrated in some way. And the 988 system will help us move that, I think, in a big way. Capacity for mobile crisis response teams. So what we've learned in spades in this, police are not really the right people to be responding to this, especially by themselves. And so our next best thing to letting the police respond by themselves is to create mobile crisis response teams where we have behavioral health providers working with the police. I think ultimately we want to move that even farther, where we don't have the police involved, and maybe the mobile crisis response team will involve an EMS person and a behavioral health person. And there's a lot of work going on in social work to now train social workers to do this kind of work in local communities. And then third, the capacity to operate an actual diversion center, a physical place where a person can be brought in lieu of taking them to a jail cell. So if the police are involved and they pick somebody up, they don't have any alternative but to take the person to jail if there's no diversion center. So diversion center becomes a major place to change this, so many people don't go to jail. And then related, crisis intervention training for police, and your director spoke about CIT training in, I think she said every single county of Ohio is going on currently. That's wonderful. And then mental health first aid for key groups in the community, so people know what they should do when they encounter somebody who's having a problem, whether it be a teacher in a school or a person who runs an elder group in the community, a group of people who get together to discuss a book. It could be almost any kind of thing. The community leaders in the community or the informal leaders need to have mental health first aid training. And some examples that I've been involved in actually myself, just to cite as examples here, and I'll wrap up in a second. The regional crisis diversion centers in Kansas. We're going to have a talk in our Legion Policy Conference in a couple of weeks by the State Association Director in Kansas about how that project is moving ahead. A county crisis diversion center set up by a county. So Washington County, Oregon said, my God, they're a suburb of Portland. We've got a big problem here. We, the county, have to take this on. We have to set up a diversion center. Fortunately, Yahoo had a building that they gave to the county that was on the metro line. So they had the building to do this. The county staffed the building initially, and within 18 months, almost 60% of the revenue of that diversion center was coming from Medicaid. I haven't talked to them for about a year, but my prediction would be it's a much higher percentage these days. An LA County police project to move crisis response from the police department to EMS responders. That's something that's really worth looking into, because what you're in effect trying to do here is decriminalize mental illness by removing the police from it, and you're trying to reposition it in the health system where it really belongs. And then finally, crisis intervention training in San Antonio, Texas. So if you haven't participated in that training, they offer wonderful training in the new homeless center that they operate in San Antonio, and they do training both there, and they will literally come out and do training in your own community. So we can put it all together. So I'm going to wrap up here. I want to now bring together the various things I've talked about. So first, community level prevention through addressing the social and physical determinants of health. And I'm arguing strongly we need to add that to our discussion of crisis response. And community level population behavioral care to reduce behavioral health crises. So those two first features go together. Appropriate training of police and key community groups, and then finally configuring a three-tiered community crisis response system inside. So they're going to be people ultimately who are going to fall through these various levels. And you need something at the top to prevent them from going down that trail, but you also need something at the bottom for people who do, and there will be people who do. So how will we respond to these challenges? A little quote from Helen Keller: life is either a daring adventure or nothing. So I'm hoping that you will want to make this a daring adventure in Ohio and move the agenda. And I know you people in Ohio take all of this very seriously and will go out and do excellent work as you always do. So thank you very much for having me today. And this is my contact information. Happy to talk further with any of you here. So I'm going to stop sharing now. And okay, very good.
Thank you for that wonderful presentation. There are a few questions. The first question is, are unpaid caregivers inclusive of parents or those beyond childcare?
Well, unpaid caregivers, in the sense that I'm talking about them, are anybody who are family members or neighbors or even other peoples in the community who care for people, but they're not formally paid to do that. So many families, have some of you will have examples in your own family where you are caring for an elderly parent, or if you're the elderly parent, you might be caring for a grandchild, et cetera, et cetera. Those are the kinds of people I'm talking about there. And that statistic was just exceptionally high. A third of those people actually contemplated suicide. And I suspect a major part of that probably was because they were not able to get appropriate support for themselves and the community because they were themselves becoming socially isolated.
The next question is, what suggestions do you have for the population that does not have access to computers or phones for telehealth? This is a struggle we're having in our community.
Okay, so, that issue comes up frequently, and I would say in general, we need to do as a field a better job of this. So one of the things that, seems to have worked pretty well in urban areas is getting a person who needs these services a cell phone or an iPad so they can tune in depending on the type of service you're doing, and getting these things donated by some of the businesses in the community. So many communities have businesses, or they have community foundations, or they have family foundations that say, we want to support our own community. If somebody goes to them and actually says, I need 50 limited time cell phones to use with a set of adults in this community have serious mental illness who need to be connected to their providers, you're very likely to be able to find entities that will help you with that. They may not help you with 50, but they might help you with 10 or 20 or whatever. And you can put together the package of cell phones or iPads to actually do this, to make it possible. In some cases, what's done is the local community mental health program has these devices, and if they are doing mobile outreach, they will take the device to the person, deliver it, so the person can be in continuous contact with them. And then they will go and pick up the device after it's no longer needed. So there are different models of doing this. And I think, it's very important, and, we need to do this to help overcome the digital divide that we all know exists out there.
Mm-hmm. The next question is, what type of training opportunities are out there for social workers when providing support to police on calls?
What I can do there is I can put whoever asked the question in contact with one of my students from USC who has specialized in that area, who has now moved as a doctoral student at USC. He's now back in DC, actually implementing that program in one of the DC universities. So if whoever asks that, if you can get their email and send it to me, I'll get them in contact with him. And he can give them line and verse there.
Another question is, there's a community size of 75,000 people, and there is interest in that community for a mobile crisis team. They've posted positions, student loan forgiveness, higher rate of pay, et cetera, have been offered, and they have had no uptake. In addition, the crisis workers have had the least amount of longevity in these positions compared to others. What do you think about using peer supporters?
So that's another whole area that's developing. And again, if there's interest in that, whoever asked that question, I'm very happy to get them in contact with a person named Harvey Rosenthal. Harvey Rosenthal is the person who leads the New York Association of Psychiatric Rehab Services, which is a very large peer support operation in New York, covers the whole of New York State. They are actually piloting the idea of using peers in mobile crisis response teams. So I think in my opinion, what Harvey and his group has done is more in that direction. They're farther downstream in actually doing this and saying what works, what doesn't work than probably anybody else. So I think the solution to the question is getting your person in contact with Harvey.
The next question is, how do you move from a traditional to a networking process from a funding and timing perspective?
So I guess several things from a funding and timing perspective. So I think you can start it almost anywhere here. You can start it with why would it be excluded in your current funding? Why would it be excluded in current funding? So the Hogg, I'll give you an example of that. So when the Hogg Foundation funded these 5 counties in Texas, they started with the traditional idea, we are going to fund 5 county collaboratives here. And what the people doing those collaboratives came to understand was this probably wasn't the right approach. So they readapted midstream in their current funding. Their funding wasn't pulled back. They readapted in their current funding. So I think that's one side of it. Another side of it is the whole issue. I think you can develop networks almost anywhere. So one of the things that I did when I was a Fed that I'm actually very proud of. So you say, what was the most important thing you ever did in your career? I would say it's bringing peers to the table. So when I was a Fed, I started listening to stories that consumers and family members told about their behavioral health conditions and their lives. And these were always just terribly wrenching type stories. They said, well, we actually need to do something about this. And we need to have you help us, tell us what to do, because you actually know more about this and have experienced this than anybody else. So I started inviting peers to all my meetings, my technical meetings, my advisory meetings, my review meetings. And of course, initially the professionals didn't like this, but I persisted in that and I learned you can't invite only one peer, you have to invite 2. You have to do accommodations. You can't pay somebody too much money because they'll lose their SSID. I learned all those things, but I persisted in it. So what I was doing was building networks inside a system that didn't support networking. So part of it is, seizing the reins and actually beginning to do some of these things inside other structures. That's how you ultimately will begin to change some of those other structures and some of the power structures we were talking about a little earlier.
Okay, we have time for one more question, and it is, can you recommend resources to better understanding the networking process?
There's a whole literature on networking strategies that is available. Yeah, just go out and look in the academic literature, and there's tons of literature on this. Building networks, how to build networks. You can go out on the internet, I bet you this afternoon, and find 500 references to that. I also, in this instance, can get people in contact with others who have specialized in that. I have a good colleague who teaches in a college in the local DC area who specializes in that, who I'm sure would be happy to talk to whoever's asking the question.
Well, thank you so much. We appreciate your presentation, and we've gotten lots of comments in the chat of how wonderful and fabulous it has been, specifically from some of our rural communities. So thank you, Ron. We appreciate you joining Ohio.
Okay, thank you. Thank you for inviting me.
Next on our agenda is Tom Craig from the PEGS Foundation.
Hello, I'm Tom Craig from PEGS Foundation, and it's my pleasure to introduce Camille Harding. Camille Harding is a licensed professional counselor in Colorado. She in her career has operated a private practice serving youth and families. So she has the direct care in her history, working the frontline treatment. Camille joined the Mental Health Center of Denver to manage a child and family outpatient clinical team. And so she has that worked and managed in a community mental health agency experience and knows kind of what providers go through. And then in 2012, Camille joined the state as the Quality Health Improvement Section Manager with healthcare policy and financing, and worked in a continuous improvement and systems change improvement kind of a role. And this is a state, Colorado. It has remote areas, urban areas, lots of geography, lots of distance. She probably needs a helicopter to do her work. It's just a big place with lots of variety of different geography. So currently, Camille serves as the Division Director of Community Behavioral Health for the Office of Behavioral Health at the Colorado Department of Human Services. So now she's working at systems change at a state level, both with rural and low population areas, oversees statewide things like the managed service organizations that provide residential and outpatient substance use treatment. She's coordinating with community mental health center contracts and the Colorado crisis services, which include the statewide hotline, crisis stabilization units, walk-in centers, and mobile response. So, and then in her spare time, Camille also chairs the Mental Health Criminal Justice Task Force that examines these issues related to behavioral health and criminal justice involvement, and the Colorado Behavioral Health Transformation Council. So she's literally working in a statewide multi-system coordination to bring about change in Colorado to improve crisis response. I couldn't be more proud to be able to introduce and excited to hear from Camille to see what Ohio can learn about how she's taking on these challenges in Colorado. Camille?
Thanks, Tom. I appreciate it. Okay, so let me figure out how to share my screen here really fast. Okay, can everyone see that? We're good? Okay, so since Tom already did a fabulous job of this, I'm going to go ahead and advance to the next slide. All right. Whoops. It's going to just keep going on me. Let me go back here. Okay. So today I just wanted to really give an overview of the crisis system, where we started out in Colorado, outline some of the specific changes to the system that we've made along the way. And then identify some quality improvement strategies that we've been implementing. I think we've had a little bit of sort of exposure to that already this morning around how you think about iteratively building out systems and thinking about changes and continuous quality improvement. And so, as Tom mentioned, I used to work at the state Medicaid agency, healthcare policy and financing, and I was the quality health improvement manager for the Medicaid agency. And so my background is in sort of thinking about continuous quality improvement and data infrastructure. So I think you'll see that as we go along. All right, so Colorado Crisis Services was established in 2014 after the Aurora Theater shootings in Colorado. We had a lot of leadership at the state level who really pushed to bring forward to the legislature the need for a crisis system in the state, which was awarded in 2014. The principles of the crisis system from the legislative declaration are listed here. There needed to be cultural competency, strong community relationships and partnerships, the use of peer support, use of evidence-based practice, build on existing foundations, and then utilization of integrated system of care and outreach to students through school-based clinics. So The legislative declaration, I think, was aspirational, and we still have a lot of ways to go to achieve all of these principles, though there's certainly pieces and parts, and we have a lot of bright spots in the system, partially because of the geography and sort of the way that behavioral health services have been established within the state. There's just a lot of opportunity for us to continue building out our crisis response system. So, I think the first 5 years of our crisis system, so when it was procured, it went to our community mental health centers. And so it was built upon the foundation of community mental health clinics that we had around the state. Our state is divided up into 7 regions, or 17 regions, and for community mental health centers. And the 17 community mental health centers at the time were part of a capitated Medicaid programs, primarily saw a Medicaid population, which meant that we really needed to work towards responding to folks that maybe were not covered by Medicaid. About a quarter of our state at the time was covered by Medicaid, and then 3/4 were not. And we wanted, because this was intended to be a system that responded to all Coloradans, we've seen some challenges there upon sort of shifting from just serving individuals who are covered by Medicaid, because a lot of our providers like to, because our Medicaid benefit for behavioral health services is pretty robust and covers quite a few services, there was a reluctance to actually respond to folks that had commercial insurance because of challenges in getting reimbursement. And then an additional sort of challenge that we saw in the first 5 years was we had a lot of variation, because every community mental health center around the states responded in the way that they felt most appropriate. There was a lot of variation, and you could go from county to county and get a very different response. And one of the challenges we saw was and whether or not the provider was willing to respond to someone in crisis. Oftentimes our crisis hotline would say, like, hey, I have a caller that's in your county. I would like you to go do a mobile response to this individual. And they would decide, like, oh no, we know that individual, we're not gonna go, we're just gonna send them to the ED. Or they would call the patient and just say, do you really need to come in? Or they would make the patient come drive to their walk-in center. And so we've really worked hard to standardize response so that you can expect a mobile response if the hotline has already done an assessment. So we were seeing duplicative assessments essentially, and differing dispositions, which became really challenging, as you can imagine. And then we saw a lot of challenges around staffing models, varying degrees of training. Lots of folks were, while I understand sort of the philosophy behind some of the staffing models, right? You're a community mental health center, you have to respond to everyone in your community. We would see a clinician that had a full caseload and was scheduled to see clients, but then they were also on the crisis team. And so they would have to stop seeing clients and then go respond to a crisis, which meant that they could, oftentimes was part of the rationale why they wanted individuals to come to the clinic rather than do a mobile response. So we've seen lots of sort of staff leveraged across multiple teams. And that means that they're not available to do an actual mobile response. And we've really tried to build out our mobile delivery system. And so we'll talk a little bit about some of the changes we made. And then we've just had really challenges around using data and clear sort of line of sight into data. And we've done a lot of work around that. So also the other thing I forgot to mention is that in Colorado, we have a state requirement that our contracts are re-procured every 5 years. And so because of that, our community mental health center provider system that it was originally awarded to, we re-procured about 2 years ago. and restructured sort of the way that the system was designed by the state in the first place. I think in 2014, everyone was in a rush to get contracts out, and it was their first sort of opportunity to think about the delivery system. And so because we've had the first 5 years to really think differently about where were the changes that we wanted to make, that led us to a re-procurement process in 2019. So this is just an example. Let's see. This is just an example of some of what we saw in the first 5 years of the crisis system, is that we had mobile crisis teams that we were funding that were primarily responding to individuals that were in an emergency room or responding to the community mental health center. So what that means is that just about half of our mobile responses were actually occurring in places that we felt like were not community-based. We're not responding to places where we thought that individuals that we wanted to have our resources, essentially, because emergency rooms right under federal EMTALA are required to respond to anyone that comes into their ED. And we just really were thinking about this as if an individual has already walked through the door of an emergency room or emergency department, they're getting charged for that service. And then to have an outside state-funded entity go to the emergency room was just sort of increasing the cost of care, and we weren't getting a ton of value add. And our preference was to really start seeing community-based response rather than emergency room response. And then likewise, community mental health centers in our regulatory framework for the state are required to be able to respond to individuals in an emergency. It's actually in their statute that they do emergency services. So they were what we call 2765, which is, of course, a regulatory reference that would mean nothing to folks in Ohio. But essentially, they're responsible for being able to navigate and respond to individuals in a crisis as part of their statutory requirement for being a community mental health center. And so when we were seeing over half of mobile responses were actually occurring within emergency rooms and community mental health centers, we did not think that was the way that we wanted to use our investment from the legislature for a crisis delivery system. And then this is just another sort of snapshot of that same data when we started really thinking about re-procurement of the delivery system and re-procuring our crisis providers. The vast majority of our mobile encounters were Medicaid covered individuals, and there was only a small fraction of non-Medicaid covered individuals that were getting responses. And so these are some of our public health data you'll see flashing up on the bottom. When we look at the unmet behavioral health needs that come from public health data, 62% of those individuals were actually non-Medicaid covered lives. So commercial covered largely, and 38% of the individuals. So it was just out of balance. Additionally, in terms of unmet substance use needs, 71% were non-Medicaid and 29% were Medicaid covered individuals. And then again, our poor mental health days that comes from our public health data set, 66 and 34%. So we just felt like the response was out of balance, and we wanted to ensure that all Coloradans had access to appropriate crisis interventions. So as we started to think about re-procurement, we actually did a large statewide convening of different individuals that had sort of a lot of opinions about the delivery system. That included providers, it included community healthcare providers, it included law enforcement, it included county commissioners, it included state level folks, it included our child welfare providers. And so we brought all of those folks I'm saying goodbye to my daughter. She's leaving for school. Sorry. Goodbye. Have a good day. Sorry about that. So we brought all these folks together and started really thinking about where do we have all the where are the bright spots in the delivery system that we want to make sure that we continue when we re-procure, and then where do we have opportunities for improvement? And so these are the 10 committee recommendations that we met for about 6 months and did a lot of Friday afternoon meetings and voted. And this is what the voting landed on, was our prioritized set of opportunities for improvement. So increasing the depth and breadth of services for children and adolescents. I'm going to talk a little bit about our next steps that we're working on related to this work. Increasing peer support in all areas. We have workforce shortages, and we have individuals that we can't always do a paired response, so a clinician with someone else. And so we thought that there was lots of opportunities to leverage peers in our delivery system. Opportunities to leverage technology and simplify our crisis line response. And we're doing a ton of work around data infrastructure. And then determining how our co-responder model and mobile services can be used in a crisis response situation. So we had a lot of conversations around, right, when is it appropriate for law enforcement to be involved in a crisis response, and when is it not appropriate? And we separately, out of the Office of Behavioral Health, fund about 40 different co-responder teams around the state that is completely separate from our crisis system. And we're undertaking a lot of work right now to try and figure out how do we tailor our response so that you get, right, if law enforcement or a co-responder team needs to be on scene, how do we dispatch that team? And when we don't need law enforcement on scene, let's figure out how to do that. As you can imagine, that's a lot of cultural change, and that's a lot of just technology infrastructure, frankly, because we have two very disparate systems. We have our 911 system, and then we have our crisis hotline. So thinking about how can we make that more integrated and thoughtful, and that's taking a bit of work. Develop and implement an outcome evaluation system. There was a lot of feedback around we don't have good data. There's gaps in our ways that we're able to look at our responses and look at our bed utilization for crisis stabilization units, look at walk-in services, and really what is a walk-in service and what is just an individual walking in for resources. Do we count that? So lots and lots of sort of, let's standardize and think about our methodologies for what we're counting and how, so that we're iteratively being able to use that information to build and improve the system. There's a recommendation to establish a leadership committee of state partners. Recommendations to improve the integration for mental health and substance use. We saw sort of very different responses for individuals that maybe had substances on board when a team was going out, and wanted to make sure that there was sort of a consistent response, and that even if you had substances, you weren't just immediately sent to the emergency room. And then lots of conversation around how our hotline dispatches teams, and targeted marketing for populations that were not served by the crisis systems, right? When we look at our data, it was hard to tell whether or not we were outreaching all communities and all populations. And so there was a lot of opportunity for us to ensure that we're meeting the different cultural needs of our communities, as well as responding to individuals that maybe would not typically access a crisis service or call a hotline. And so there was a lot of work around doing some targeted marketing. And then exploring a 3-digit number for our crisis line. This was before 988 was a thing. And then of course, 988 occurred. So we have a lot of opportunities there, but there was a lot of conversation around our statewide hotline is not a number that anyone remembers or uses. And it took me a good year and a half to remember it myself. So yeah, that was completely understandable. So those are our 10 committee recommendations that a ton of folks around the state weighed in and made recommendations for improvement. So we took this feedback and essentially ended up reprocuring our delivery system and did an RFP. And so when we reprocured the system, we actually established administrative service organizations, meaning that rather than each community provider sort of operating independently, that we felt like there was a ton of administrative work that needed to be done in the delivery system. And so we actually took the concept from a managed care sort of concept and said, we want the responsibility of the delivery system to be handled by single regional entities. And so we established administrative service organizations, and we'll talk through what that means in a little bit more detail. But essentially we aligned these ASOs, as we call them, with our 7 Medicaid regions and used the same geographic catchment areas, and so that there was alignment in terms of geographic regions. And in some cases today, we have the same provider that oversees a Medicaid region is also our crisis response administrative service organization. We also made a ton of requirements around data and technology so that we could have clear line of sight into what is occurring within the delivery system. We put a ton of criteria in around data and technology service standards and protocols. One of the items I mentioned a bit ago was the fact that we had a lot of variation in the system, and one crisis response provider was not the same as the next crisis response provider. And we wanted to start making sure that you could at least have a floor of expectation across the state, while we know that there's going to be geographic sort of differences because it's a vast state, and there's a lot of different communities and a lot of different populations. We still wanted to make sure that there was at least a floor of expectation about what type of responses would be occurring. And then we really prioritized mobile crisis response. We were not, as I mentioned before, our mobile crisis response, we didn't consider to be really a good use of resources, and so put a lot of criteria in our reprocurement and in our contracts around what that needed to look like. So here is a map of Colorado that shows our regional administrative service organizations. Region 1, as you can see, is sort of the western part of the state, and it's pretty large geographic catchment areas. So they have a lot of complexity in that region, as well as region 4 and 5 and 6 are big rural regions. And then the metro sort of center of the state is smaller, but by population, there is about 200 to 300,000 individuals that are covered in each of these geographic catchment areas. So as we reprocured and awarded contracts to administrative service organizations rather than directly to providers, we really thought about what are the responsibilities of the administrative service organization versus the responsibilities of the provider that may be delivering a mobile response or has a crisis stabilization unit or is doing respite services. All of those sort of services, we really said, like, let's let the providers do that work because that's important work. And then the administrative work, let's consider what needs to be held at sort of a regional catchment area. So how we kind of approached that is one that our crisis system, when it was originally awarded, was about $21 million of state general fund. Since then, we've gotten additional resources from the legislature and then added in some additional federal block grant from SAMHSA federal block grant funding. And so altogether, our total budget for our crisis system that is not, is really, it's about $36 million. About 5 million of that goes to our hotline, who is a statewide vendor. And then the rest of it is divided up to really what we describe as capacity budgets. It's to pay for staffing and the infrastructure. And the ASO, we divided it up based on population and weighted it based on rural regions, because we know that the response in rural regions is more expensive. And so we came up with a sort of per member per month kind of concept and awarded that budget to each of the administrative service organizations. So the administrative service organizations are responsible for developing the network, contracting with providers, making sure that they're collecting fiscal information, budgets, and also data on the delivery system. And then we established sort of an indirect rate for the administrative service organization. That was a range. We said you can go from your total budget, you think about what are the responsibilities that you're going to retain at the administrative level and what are the responsibilities that you want to give to the provider. So if you're going to build your own single infrastructure for data, that we know that's going to be more expensive than just sort of saying, provider, send us your data. We also said, are you going to retain, we had a responsibility or a requirement in the contract that said you must follow up with every patient that has any level of risk based on the Columbia suicide tool. If anyone has a level of risk, then you must do telephonic follow-up with them after your interaction within the crisis system within 24 hours. If you're going to retain that at the ASO level, right, again, our thinking was you could have a little bit more of a budget at the ASO level. Many of our providers chose to delegate that to the crisis response providers, which makes sense because they're the ones that had the interaction. But we gave them a range and essentially said your ASO can think about what your budget needs to be at the administrative level, and we gave them a range up to 20% of the total budget. Many of our metro area providers are operating at a 5% administrative rate, which is pretty low, and they're doing a fantastic job, I have to say. And then we also gave them the opportunity to think about performance-based payments and really start pushing sort of quality improvement in the delivery system. Then the next piece that we really required of our administrative service organization is starting to standardize protocols between crisis providers and other service providers. We wanted to make sure that there was, like, all of these partners in the community could expect a certain level of response. And so we put a ton of criteria in around developing protocols and standardizing responses. So for example, we had many of our providers that historically had been responding to individuals that were already in an emergency room. Many of our rural critical access hospitals and other emergency rooms in rural communities were challenged by the fact that we had put this criteria in, and we said, you know, we're fine with our mobile teams responding to EDs if there is an MOU, a memorandum of understanding that's developed between the crisis response provider and the ED, because we knew the volume of individuals in a rural community is going to be much lower than, say, one of our large metro area hospitals that should be able to staff a behavioral health provider in their ED because they just have a ton of volume and they're going to see individuals on a regular basis. Our state-funded system should not be offsetting those costs for a metro area emergency rooms, but in a rural community where workforce is a challenge and you're just not going to have the same volume of individuals coming in the behavioral health sort of need, it was fine that be developed. It was just standardize a protocol, set the floor of expectations so that all the partners involved know what they can expect, and that there's clear sort of guidelines and thinking about what that response should be. And so our providers are continuing to work through standardizing protocols and thinking through different sort of scenarios and use cases, and working with all the partners in their communities to develop sort of operational procedures so that it's clear and all the partners are aware of sort of this is what this needs to look like ongoing. Then, of course, I mentioned data and technology. We put a ton of criteria. I'm not going to spend a ton of time here, but we did talk about sort of how do you leverage a state health information exchange. So you can look at if you're seeing someone that has presented in a crisis, that you can leverage health information exchange and query in and say, like, it looks like this patient has actually been in the ED 3 times in the last month. Like, we should really think about our response and what that needs to look like to make sure that we're stabilizing the individual in a meaningful way. Or maybe that person has a physical health condition that we really need to be thoughtful about how we approach sort of their wraparound services post-discharge from a crisis intervention. So we've really encouraged our providers to get connected to state health information exchanges, and we're still doing a lot of work around that, and we're really keeping an eye out for the HHS to roll out additional guidance around HIPAA and 42 CFR. We know that there's new HIPAA federal regs out that we're wading through, that we're doing comments on as well, because we think that we really need to consider technology infrastructure and how you do care coordination and really respond to folks in a different way, in a more comprehensive way than just sort of the crisis intervention is an intervention, and then we'll just like send the individual back out into the community. And we want to make sure that we're thinking more comprehensively about individuals' needs and doing a lot of wraparound services and getting them connected to the right level of service. So we have a ton of work that's happening around that. And we think that data infrastructure and technology are the way to sort of solve for many of those issues, because then you have line of sight across delivery systems. So I could talk about technology all day, but I'll spare you. So the next piece that we really did a ton of work around is standards for mobile protocols, and really thinking about let's develop protocols for when is it appropriate for just an individual to go to community-based response? When do you need paired response? How do you prioritize community-based response? I already mentioned that we worked on MOUs with hospitals and follow-up criteria. And then the thing that I think that was the biggest deal that we did in our reprocurement around mobile response is that our statewide hotline needed to be the centralized sort of place to dispatch all mobile responses. We saw a lot of instances in where in the first iteration of the system, we had community providers that would just go out on a crisis response because someone called the community mental health center directly. Then the hotline would call and say, hey, we have a patient that needs to be responded to. And they would say, sorry, our team's gone. They're already out on a call. And so then, of course, what would happen is that our hotline would inevitably end up just calling law enforcement to do response. And so we really did a ton of work around standardizing sort of a way that the hotline is the centralized sort of resource for dispatching mobile response around the state. And if they chose to take a team offline, because we didn't want to like disrupt sort of community relationships, they needed to notify the hotline that like, hey, we're going out on a response. Someone's called us directly, whether it's law enforcement or whomever, that we need to go out on a mobile response. They just needed to notify the hotline so the hotline could plan ahead and notify a local or nearby team to do a response should that occur. And then additionally, if they've we wanted to make sure that, again, our data, we wanted to know when people are being responded to, what types of issues. So if a team responded, they needed to circle back with the hotline and make sure that the disposition was documented. One of the challenges of our hotline is that they wouldn't get any sort of information about what occurred on scene. And so they would continue to call the patient to check in on them. Meanwhile, the community provider had already been out, assessed, maybe safety planned. And if the hotline didn't know that, the hotline kept calling and checking on the patient. And so we wanted to make sure that we got that closed loop and that the disposition was closed and that the hotline knew that that patient had been safely taken care of. And then the last thing is that we required that if law enforcement or child welfare called for mobile services, they just had to go, like no question, just go. Because we had a ton of sort of stakeholder feedback in our community convening that law enforcement was just simply frustrated with the lack of response from our delivery system, and as was child welfare. And then finally, we have respite services that are covered in our contracts as well. What respite looked like in the first 5 years of our delivery system was that it was really facility based, and oftentimes there were individuals that maybe were homeless or discharged from an ED and would get placed in a respite bed for 14 days at a time. And then, because that's our rules said 15 days was the max. And then they would release them on the 14th day and then just readmit like 3 days later. And while, right, like we appreciate the fact that there's individuals that are homeless that needed sort of respite supports, we really wanted to get clear about sort of the standards and protocols for when respite is appropriate and when we really need to be thinking more comprehensively about housing solutions, and working with our local housing departments around, like, let's think about vouchers and let's think about other opportunities to support individuals that are homeless rather than just leveraging crisis resources for that. And so we put more criteria and standards, and the regions have worked on developing what those protocols are and what they think is appropriate with their partners. And then also, one of the things that we really prioritized is let's think about respite care for individuals with intellectual developmental disabilities or children and adolescents, and think about respite as in-home services rather than taking someone out of their home and putting them in a bed. So we've seen a lot of sort of examples of that. We really encouraged our administrative service organizations to think about innovation and opportunities to build out what we had in place. So the areas that we're really working on quality improvement right now is a technology platform for the hotline, considering connections to health information exchange, training for all mobile providers, hospital follow-up, and making sure that we have appropriate response for children and adolescents and individuals with intellectual and developmental disabilities. And I trying to keep track of my time. So I'll just kind of talk through some of the things that we're working on right now. Some of them are a little bit closer to finish than others. Technology platform for our hotline. Our hotline was just really operating with sort of an older infrastructure, and we helped supported a purchase of a new technology platform that really is more like an electronic health record that allows them to see when a call comes in, right? If a caller's previously called from that same number, it allows them to document the information and be able to retrieve that information. And then it allows also for some dispatch. So we help invested in sort of a statewide platform for the hotline. Where we're at right now with that is that we're really thinking about connections to health information exchange. I mentioned that a little bit previously, but our two health information exchanges have a ton of sort of social determinants of health information and healthcare information that we think is important for our providers to be considering when they're responding to individuals in a behavioral health emergency. And so we're really trying to push that to make sure that we're getting more comprehensive sort of thinking about wraparound services. One of the other areas that we're working on at the state, which is entirely separate from the crisis system, but we fund all of our jails around the state. We have 54 county jails or regional jails, and we've been supporting them with some state general fund to build out their behavioral health services in the county jail. And one of the areas that we've really been working with them is health information exchange. So we have several jails around the state that are connected to HIEs that are able to, when they book an inmate in, look at their longitudinal record and say, oh, it looks like this person has been on metformin. I got to make sure that we continue to give them that med. Or this person has been previously seen at the Mental Health Center of Denver, and we need to coordinate care back with their provider because the length of stay in jail is pretty short, about 3 weeks most of the time. And we want to make sure that we do warm handoffs. So we've been doing a ton of work with our jails around sort of thinking about that as healthcare. And the opposite is true for the crisis system. We really want our crisis providers thinking about like, oh, this patient was just booked into jail 3 weeks ago. We need to do a really good job about thinking about getting them connected to care rather than just doing sort of our moment in time intervention. So we're really building out that infrastructure. And then one of the other areas, we saw a lot of variation around the level of training and the level of sort of the comfort level of our providers being able to go out into the community and do a mobile response. So we hired a vendor to come in and develop a robust training and required that all of our individuals operating in the crisis system participate in a standardized training that included both sort of environmental and safety. So thinking about, I'm on scene, what do I need to be considering? How do I think about animals and weapons and sort of environmental safety? But how do I also do a really good safety risk assessment? I had mentioned before that we had folks that were leveraged across the system and were working on multiple teams, and crisis wasn't the thing that they just did. So we just wanted to make sure that everyone had a really good skill set around safety risk assessment. And we did some pre and post testing about where folks started at and where they moved to. And we're going to continue rolling out sort of iterative training for our crisis providers because we know that there's turnover, but we want to make sure that all of our staff responding are capable of doing really good safety risk assessments. Next, we have a hospital follow-up programming. So we've been working on investing in a care coordination infrastructure at our state hotline. So if someone hits an emergency room and is there because of a mental health or substance use treatment need, that we want to make sure that the hospital connects them to the hotline, and the hotline really does a lot of check-in with them and hospital follow-up to make sure that they get connected with care. We know that we have challenges with access in our delivery system, and sometimes people will hit an emergency room and then don't get followed up or can't find a provider, or there's gaps and it takes them 30 days to get into care. And so we have really built this care coordination team at our state hotline that does telephonic check-in and helps get individuals connected to the right set of services. In particular, veterans is really the community that we're trying to target because we know our veteran suicide rate is really high nationally as well as in Colorado. And so in particular, if a veteran is presenting at an emergency room, we really want to make sure that these individuals get connected with our hospital follow-up team at the state hotline. And one of the other things is we're trying to recruit veterans that actually work within the hotline. That's proving to be rather challenging. So we have a separate group really working on how do we staff our hotline with individuals that our veterans, because we just think that's a better sort of way to be culturally competent. And so we're working on building that out. And then finally, children and adolescents and individuals with intellectual and developmental disabilities. We actually just yesterday got about $1 million request funded by our state legislature in our figure setting to build out content and curriculum to support training for our crisis providers around the state to respond to children and adolescents and individuals with intellectual and developmental disabilities. We've had a ton of sort of feedback about our system is not really tailored towards these two sort of populations, and we need to do a better job. So we wrote a budget request, and it was approved yesterday to start really building that out. In particular, I practiced as a child and family clinician for a good 2 decades before I came to the state. And I know that oftentimes the folks that staff our hotline and the individuals that are working in our delivery system are relatively new to new to the work, and children and adolescents and individuals with intellectual developmental disabilities need sort of different approaches and different interventions. And I know some of the feedback we received from our hotline is that they're relatively young. They're talking to parents about how to respond to their kiddos, and they don't have kiddos themselves. And so we want to make sure that they're equipped with the skills to be able to say, like, this is the way that you can help support your teen. This is the way that I might have this conversation with your child or adolescents if they're just calling for support. And so we're going to work on building that out. And we're creating essentially a virtual learning management system so that we are able to retain this information, and individuals that are working across the state doing crisis response will have the opportunity to go in and watch virtual training ongoing. So those are 2 sort of next steps that we're working on. And then the one other thing I would add about children and adolescents is that we did a deep dive into our regulatory framework, and we knew that we have 2 separate sections of statute that are contradictory. One says that children 15 and up can consent to their own treatment. And then we had a separate piece of legislation that was passed in a couple of years ago that says 12-year-olds can consent to their own treatment, but it says psychotherapy. So there's lots of sort of, well, psychotherapy is not a crisis response, is it, or is it not? So we're actually working with some legislators this year to introduce a bill to clean that up that basically says crisis is covered for individuals 12 and up, and they can consent to their own crisis response service. We had lots of reports where crisis providers would go into a school, but would not see the kiddo because the parent had not consented to their treatment, or they couldn't get a hold of the parent. And so they're just in this position of not doing the response because of liability and sort of their organizational policies say 15 and up. And when we have a suicide rate within Colorado for our 10 to 14-year-olds that is continuing to tick up year over year, we were pretty distressed about the fact that children and adolescents were not getting the appropriate response. So we've actually partnered with our legislature and and are seeing some cleanup language introduced this session to fix that sort of contradictory guidance that we have. So with that, I think this last slide is really just in the time of COVID, it's just a snapshot of our uptick. We've just continued to see our crisis hotline have record-breaking number of calls and texts during COVID. And this is just sort of a trend of the calls that we've seen to our state hotline. During COVID, seen a ton of volume and are now, our crisis hotline is staffed with over 100 staff that respond 24/7. And we continue to see that climb year over year. The one other thing I would say is that our crisis hotline actually does the vast majority of responses and does not require, I think only about 5% of the calls that they take actually need a mobile response, and they're able to support most callers with resources and referral to the right set of services. We have a peer staffed support line, which we call our warm line. And they do a fantastic job of supporting individuals that maybe just need sort of some additional support. And then we've added text and chat in the last several years because we know that's a more appropriate way for adolescents to interact with the system rather than picking up a phone and calling. With that, I'm going to conclude my presentation, and I'm happy to take any questions.
Camille, thank you so much. There's lots of questions. Personally, I have 2 pages of notes, so we will definitely be in contact shortly after the presentation. I love the data infrastructure and technology piece of your presentation, and the ASO piece. Those are real thought-provoking for us at the state. There are tons of questions around the sample data reports that Colorado uses, the standards that Colorado uses for your standardized protocols. So if there's an opportunity to share those with us, we would be able to post those on the OMOS website as we get that information from Camille. One direct question, Camille, is whether all mobile crisis responses are paired with law enforcement, and if not, what training was put in place to keep clinicians safe while visiting homes? And you've kind of touched on that a little bit in your presentation, but is there anything you'd like to add?
Yeah, so not all responses include law enforcement. So because, again, we've left this really to our administrative service organizations to think through what's an appropriate response. We do have some regions where the contractor has been doing this for decades. This is what they have specialized in, and actually they have a really good partnership with law enforcement. And so they kind of will say, we're going, we don't need law enforcement. We know this individual, we've got this. And so there are cases where law enforcement does not go. There's other cases where, right, it's a pediatrician's office calling or a school calling. We don't think law enforcement needs to go to those responses. So we really try and encourage them to think about, let's think about what's the best response. And so we've really worked on trying to parse that out and think critically rather than just law enforcement goes all the time. There are some communities that have chosen that law enforcement goes no matter what, and then they kind of will hang back. And then as soon as the clinician says we're good, they'll leave the scene. So it sort of depends, and there's still a ton of work to do on refining that. And I think part of it's really dependent upon our ability to get really clear with law enforcement and build out protocols. So we have a separate group that's working on sort of like, how do we refine this culture and think about tailoring it, and also partnering with our 911 dispatch. That's some heavy lifting, and we've been meeting for over a year and are having tons of like really interesting conversations, and we have a lot of ways to go. And then I think the other thing is just the training. We've really said, like, think about your environmental sort of safety and think about your, is it appropriate to have law enforcement? Because in some cases it's going to exacerbate the situation. And so we've done a lot of the standardized training. We have a long ways to go. I wouldn't say that we've like got this figured out and we can check that off our list, but certainly we're really pushing folks to have those tough conversations and think critically about protocols and responses in their community, and then kind of leave it to the ASO and the partners in the community to develop what they think is appropriate. Meanwhile, right, as we build out our technology infrastructure, I would like to get to the point that we're publicly reporting the number of times that law enforcement's on scene for a response and the number of times that they're not, because sharing data publicly is a really good way to change behavior.
The next question is, can you speak to how your state has worked to retain crisis workers?
Yeah, so that is a really interesting question. So we actually don't have a ton of good data on sort of the turnover of staff. And I think part of what I think that we're doing is making sure that the folks that are doing crisis response are really comfortable with doing crisis response. And so I don't have any concrete sort of strategies that we've employed around turnover, but I will say that we've had some conversations with some of our rural partners who've said the fact that we've required more strict protocols and folks trained in crisis response has sort of resulted in the folks that are good at crisis response really dig it and love it, and they're happier in their job because they're not feeling so sort of torn across having to do multiple things in multiple areas. And this is their full-time job, is doing crisis response. And that's their thing that they love. And so there's more satisfaction, and they see a less turnover just from sort of simply saying, like, this is your responsibility. Let's get really good at one thing instead of expecting you to be good at all things and spreading people too thin. So that's what I'd say about that. But we don't have any sort of real concrete data or information on that. So it's an interesting question I'm going to write down for myself.
There's a question on, you touched on this. Do you have any incentives to make the mobile response team positions more enticing? And I think you touched on it with your previous answer, but is there anything else you'd like to add?
Yeah, we've left sort of incentives up to our administrative service organizations and said, you can take a portion of your budget and use it for incentives in any way you want. And though I don't have any examples of them using their incentives to do staff sort of retaining staff, I do think that there are some of our providers that have actually increased the salary for their mobile response providers, because we know it's stressful. And then we've also, part of our training when we did our standardized training was really thinking about the burnout for providers that are doing this type of response. And that was a portion of the curriculum, was thinking about burnout and how do you support one another, and making sure that our staff that are doing this type of response are getting good clinical supervision, as well as just sort of a support in general, because we know it's stressful.
And Camille, this is a combined question. It's a combination of several questions. There's a request for what type of safety risks do you use? And then a request for Colorado's standardized protocols that you mentioned. And then you mentioned that you're collecting data from your ASOs, are collecting data for your crisis response systems, and any type of data collection samples that you can share with Ohio would be great.
Okay.
And I have another question about the safety risk assessment tool. So since we have a few minutes, if you can talk about that a little bit.
Yeah, so our actually safety risk assessment tool, we actually hired a vendor that's done this in other states. We spent a lot of time sort of doing an initial pre-assessment of all of our crisis providers to see where they had gaps and where they were solid. And so we don't have, I can actually send you the information that he developed. And sort of the way that all was rolled out. But we don't have sort of like a particular tool. We do require the Columbia be administered to anyone on scene that is responded to. And then anyone with elevated risk needs to have follow-up. But then in terms of the safety risk assessment, it's sort of a broad framework for thinking about safety and risk, and it's in our training curriculum. So I'm happy to send you what we have and any links that have been, I want to say we have a lot of public links and sort of what our pre-assessment looked like and post-assessment. And the other thing was we're still building out our learning management infrastructure to put that content up on a public facing website so all of our crisis providers can continue to use it. But I'll send you what we have developed. And then also any protocols.
That's great.
The one other thing I would say about data collection is actually we've used a lot of claims data. So I don't know if you received claims from your state Medicaid agency, but we use claims data in the place of service. And then we have a code that is, if this is a crisis response, is required to be coded on it if it's going to be counted as a crisis service. So I'm happy to send that as well.
Thank you. The last question is, could you share the contact information for the consultant you work with or your mobile crisis providers?
Yes, Harris Logic is their name, but I'm happy to send it along.
Thank you. Well, Camille, thank you so much for your presentation. It was rich with information. Ohio is definitely going to be following up with some additional information and requests from Colorado. You've done a great job in Colorado and gave us a lot to think about. So thank you so much.
Yeah, thanks so much for having me. I appreciate it.
Next on our agenda, I'm going to turn this over to Soli Hernandez to introduce our next speaker.
Soli, I think you're mute.
Can't hear you solely.
So it looks like we're having a little bit of technical difficulty. So if you give us a second, we'll be right back with you. So our next speakers are Chaz, Canter, and Margaret Sterling. We had a little technical difficulty there, so we weren't able to get those introductions out, but we appreciate you joining us today, and let's see if we can hear your presentation.
Okay, I'm going to start. I'm Margaret Sterling, and I work with Hopewell Health Centers down in southeastern Ohio. I am the director of the Adam Amanda Mental Health Rehabilitation Center, as well as a group home that we just opened down here, and I'm also over the crisis hotline. And I'm presenting today with Chaz Canter, who is the coordinator of crisis services for Athens, Hocking, and Vinton counties. And we're going to talk a little bit about how things used to be when I first started 17 years ago, some of the changes that have happened, and then the things that we're going to be doing moving forward to improve a system that we've already, I feel like we're doing pretty well at, but there's always room for improvement. So let me get, okay, so we have mental health agencies in, I believe, 18 counties down here, but there are only 6 counties that have 24-hour crisis services. That's Athens, Hocking, and Vinton, and Gallia, Jackson, and Meigs. So today we're just going to be focusing on Athens, Hocking, and Vinton because that's where Chaz and I both cover. And some of the things that we'll talk about as we go further will be things that are expanding out that we're very, very excited about. So the current continuum of care that we have in Athens, Hocking, and Vinton County has a lot of different layers. The first being our crisis hotline, which currently rings into our crisis stabilization unit and is answered by residential staff. We have pre-screeners that work in the community and in our outpatient clinics to do pre-screening, determining level of risk, and if people need to be hospitalized or diverted to the crisis unit, or if they can do safety planning and go home. They also link people with our outpatient services. We are on site at our regional jail as well as 2 hospitals, the only 2 that we have in our area. We have, like I said, our crisis stabilization unit that covers Athens, Hocking, and Vinton counties. And then the Adam Amanda Mental Health Rehabilitation Center, which is housed with the crisis unit. And that actually covers 21 counties that feed into Appalachian Behavioral Health Care, the catchment areas. And I'll talk briefly about that a little bit later. So I'm going to go back to the way things used to be when I first started. The total number of pre-screens was fairly low. I can remember being the one person on for a few days at a time and getting maybe 3 or 4 calls. And now I couldn't even tell you the number of calls that they get a day. I'll leave that to Chaz to tell you. Back then, we also used to have a lot more availability of beds at Appalachian Behavioral Health Care, which is housed right next to our outpatient clinic in Athens. So I can remember being able to call over there, say, hey, I have this person here in the clinic. Can we get them admitted and walk the person over with the pink slip and have them admitted? There wasn't as much focus on medical clearance. I think probably because there was not so much focus on dual diagnosis at the time. And like I said, there was one pre-screener for every 12-hour shift. And then we had a couple of contract people that would come and do some of the overnights. But really, it was myself and another pre-screener working backward shifts from each other and trying to keep everything going in our 3 counties. And then we had one backup supervisor that could give us advice, but not so much come out and help us when things got overwhelming, because eventually, as we all know, they did start to get overwhelming. We did have CIT training in place with local law enforcement, but there was still quite a bit of conflict and not really open lines of communication between law enforcement and mental health. And then our crisis stabilization unit had 8 beds, but we didn't have any clinical staff. We would allow people to come in the morning, leave throughout the day, and come back at 9 o'clock at night. And so really, we weren't doing much to assist with helping people get past or through their crisis situation. And then we did not have a step-down unit that would take people from a hospital and provide a longer length of stay to kind of decrease the chance that they would go back into the revolving door and back into the hospital. The other thing with hospitalizations, which I know everybody in Ohio is aware of, is that the amount of forensic beds in the state hospitals has increased exponentially. And so we don't have availability of very many beds at the state level. So a lot of our individuals that we're pre-screening are being sent an hour or more away, which makes it difficult not only for the individual that's having to go that far and not have support when they get there, but it's difficult for us to coordinate care from that far away and get people back down here and into the services that they need. And like I had said, the numbers have continued to increase just a huge amount. So I'm going to pass it over to Chaz, and he is going to talk a little bit about the way things are currently with crisis services and things like that.
Yeah, thank you, Marge, for that great introduction. So I'm going to talk to you a little bit today about how things have changed over the past several years. So when I had started about 5 years ago, so back in 2016, 2017, we had completed maybe 930 pre-screens in 1 year. So that breaks down to about 77 pre-screens a month. So if you fast forward to 2020, looking at last year's numbers, we completed about 2,495 pre-screens in a year. So the number changes astronomical. We are now doing 208 pre-screens to 230 pre-screens a month. And these pre-screens are at Hocking Valley Hospital, they're at Hopewell Memorial Hospital, or they're here in one of our behavioral health clinics. And I'm just speaking for Athens, Hocking, and Vinton counties, but we also cover Gallia, Jackson, and Meigs. We have 24-hour crisis in those 3 counties as well. with higher needs comes higher demands. So what I have done is we went from 2 to 3 pre-screeners as the whole crisis team to 6 full-time pre-screeners. We have 3 contract pre-screeners. We hired on a hospital liaison. And our hospital liaison, he plays a very important role in hospitalizations. So our chief clinical officer, who is David Chinkelberg, he's wonderful. He has allowed us to hire on several staff to really help with our community members in crisis. So Dan's main role is, and thank you for this, David, is to get our patients in to see an intake coordinator and a psychiatric provider within 2 weeks and no later than 30 days. So Dan plays a huge role in getting people in to see providers so they can remain in the community and stay stable in the community. We've also hired a crisis CPST provider, so a crisis case manager. I went to my chief clinical officer again and said, one of the main barriers that we are seeing in people being rehospitalized is there's no one there for them when they come out. Dan's wonderful. He sets up appointments for them. He coordinates with all teams and makes sure that they're coming to appointments. But I really need someone who can be in the community, either going up to these hospitals and taking them back home, because our patients are an hour and a half away, which is a huge barrier for us. And I need them in the homes if it's wanted, setting up a pill box or helping assist with meds, helping assist with resources, and helping assist our patients come into the clinic and come to their appointments. So that's been wonderful as well. Within this, we have also hired 2 zero suicide coordinators. So we received a grant a few years ago for the Zero Suicide Initiative. Within this initiative, we have been able to roll out the Columbia Suicide Severity Scale across all of our behavioral health providers, so that is being administered to all of our patients on the behavioral health side. We were also able to have Oakland Memorial Hospital start administering this to all of their patients when they come in the ER, whether they're in crisis or not. And we also have this rolled out to Hocking Valley Hospital emergency department. So they're administering the Columbia as well. So this has been a really big tool for us and our community members, so we can really capture all of our patients who may be in crisis or show up in an ED and may not express suicidal ideation, but we're capturing them thanks to this tool. Our goal this year is to roll out the Columbia to our primary care side. So that way we're really capturing all of our patients within this initiative. One of the biggest barriers in Southeast Ohio, because we do cover 3 counties and the majority of our community members and patients end up at Oakland Memorial Hospital. So when you have 3 counties, you're looking at a sheriff's department, 3 different sheriff's departments, 3 different police departments, Ohio University Police Department, Ohio University as a whole, and 3 different emergency EMS departments. So what we did was, because there was a lot of miscommunication, a lot of lack of communication, what we did was we created a crisis work group that we hold every 3 months, where all 3 sheriff's departments, all 3 police departments, all hospitals, including Appalachian Behavioral Health Care, Ohio University Dean of Students comes to this meeting, as well as Ohio University Police Department. And what we do is every 3 months, we get together at this crisis work group and we talk about what's going right, what can be improved, and how we can better serve our patients in the community. So that is our current state of affairs. We've expanded exponentially over the past several years, and we have a lot of plans to move forward. So I'm going to go ahead and let Marge talk a little bit about respite and Adam and Amanda, which we use quite frequently. We have a very good working relationship. Marge and I talk daily because a lot of our patients go to Adam and Amanda in respite, and they've been a phenomenal resource here in Southeast Ohio for assisting stabilization for our patients who have been hospitalized or who we've been able to prevent hospitalization for.
Thanks, Chaz. So currently our crisis stabilization unit works in the same building with Adam Amanda Mental Health Rehabilitation Center, and we share the same staff. Adam Amanda was opened in late 2018 after we added on to our current crisis unit. And as I had said earlier, back then, we didn't have any clinical staffing. We didn't have any kind of focus on assisting people in crisis to resolve some of those issues. And so with the Adam Amanda program, we have clinical staff Monday through Friday, therapists, we have case managers, we have admissions discharge coordinators, we have psychiatry that comes in twice a week to be able to see the individuals that are coming out of hospitals so that they can remain stable on medications, because as we all know, the stays in hospitals have gotten way shorter, with the average for private hospitals being 3 to 5 days and the average for the state hospitals being about 7. So the medications are not having time to get fully into people's systems. So with the step down program, we're able to take referrals and get people in here and keep them for up to 90 days, give the medication time to work, assist with connecting them with services either through Hopewell Health Centers or in the county of their residence, which ideally they'll be returning to once we've gotten them stabilized. I know that Camille had mentioned that in her state, the length of stay for crisis stabilization was 15 days, and so they usually discharged at 14. And for here, our length of stay for the community admissions is about 14 days. And then for the hospital discharge step down programs, it's really individualized based on what the person needs. And I didn't mention earlier that Hopewell Health Centers, in addition to having all of these mental health care sites, also is linked. We have primary care. We're a federally qualified health center, lots of primary care options. We have dental options. So really across the board, we can connect people with a whole health kind of service, not just the mental health piece. One of the really important things that we found in rural mental health is that training is essential, not just for our staff, but for the community, because not every person that is in crisis is going to come to the crisis team and say, hey, I'm in crisis. They're going to enter the mental health system in so many different ways, either by law enforcement or at the emergency room or at their primary care doctor. And so everybody at any point of entry into the system has to be aware of how to funnel people to the correct service. And oftentimes, like I said, crisis services is not the first person on scene right now. First responders are the individuals that are showing up, dealing with the immediate crisis, getting the person to safety, and then handing them to us to move forward. So I'll start with talking about the training that we do that's specific through Hopewell Health Centers. And the first one is AMSAR, which is Assessing and Managing Suicide Risk for Behavioral Health Clinicians. That is not specific to Hopewell, but I am a trainer for that. And we decided that training all of the clinical staff in how to do assessments for crisis services and how to manage suicide risk is essential, because not everybody is going to come to the crisis team immediately. So everybody needs to be aware of how to work with somebody that's at risk, and get more comfortable with that. So as of now, we've trained 200 plus people that work at Hopewell in this method. The non-clinical staff gets trained in QPR, which is question, persuade, and refer. That, excuse me, that training is done by our zero suicide staff. And basically everyone that's non-clinical goes through this training so that if they come into contact with somebody that's in crisis, they also know a good way to respond and what to do to get the person to safety and to whatever needed area they are in. we've talked in a couple of the previous training or sessions about CIT training, and I'm biased because I'm a part of the CIT team down here, but we do a CIT training annually. That's a 40-hour. We spend the week before Thanksgiving with officers, and we've gotten almost 100% of the individuals down here trained. Because we work so closely with law enforcement, we want CIT trained officers to be able to respond to our individuals in crisis if law enforcement is needed. We've also opened that up to EMS workers, and we do advanced CIT courses. We try to do those annually, but COVID has put kind of a hitch in that right now. But I want to say 2 years ago, did an advanced CIT training with our dispatchers from Athens County and just educated more on different ways to talk to people that are at suicide risk, to keep people on the phone, to do active listening, all of the things that we want all of our clinicians to be able to do. And then within Hopewell, we also do disruptive behavior management training, which is specific to crisis de-escalation and safety. And that's something that most of our staff, I believe, do annually. So, like I said, with COVID, that changed the way a lot of things all over the place, the way that they were working. So I'm going to pass it back over to Chaz to talk about some of the specific issues that the crisis team came across with COVID and how they managed those.
So I'm going to piggyback off of what Marge said a little bit, and she and I like to joke a little bit because we say that our pre-screens went from 77 a month to 215 a month because we trained our CIT officers and our EMS personnel so well. But and that's been a huge part of the emphasis on that training is if you have a question, don't question, bring them to us and let us be with our community members and let us make that determination so you don't have to. So we love that training, and we truly believe that because we have seen such higher numbers in our emergency departments and in our clinics that we have trained them to the best of our ability. When we're looking at, so I'm going to shift gears and look at some of the challenges that we have faced with COVID. So again, I have to brag on our chief clinical officer again, because he always seems to be like 2 steps ahead of the game. So when COVID had hit, we were kind of worried about how we were going to be in the emergency department and try to remain safe when seeing our patients. I know there was a lot of questions in the previous presentations about retention of crisis workers. Most of our crisis workers have been here 10 years plus. I think the longest ones were Marge and another one who have been here for 14 to 17 years. So we're looking at a combined experience of like 65 years on our team. So we're very fortunate in that aspect. So what we had done was we had worked with Oblenus, the regional jail, and Hocking Valley to take iPads over, since DeWine extended the telehealth to include crisis. Thank you for that. So we took our iPads over to the inpatient units, the emergency departments, and we set up GoToMeeting on those, made sure we were on a HIPAA compliant platform, and we're able to meet with our patients via telehealth in those emergency settings. The only real barrier that we had was rectified pretty easily. We just had to take the physical copies of the original pink slips to the locations. The good part about Oblenus is we share a parking lot with Oblenus, so it's about 10 steps away, but we take pink slips up to Hocking Valley as well. So that was really the only barrier that we experienced, which was pretty fortunate for us, since, I know that this is an unprecedented time. We're very excited to get back in the emergency departments. But I'm going to shift gears again, and speaking about emergency departments, we're going to start looking at the future for crisis services for Athens, Hocking, Vinton, and Guyot, Jackson, and Meigs. And I'm going to let Marge start with the call center and Lifeline.
Yeah, I wish that I could express, and I hope you guys are all feeling how excited we are about being able to move things forward in crisis services, not only in our area, but with the focus on the state level of improving crisis services across the state. I hope that you guys are all as excited as we are for the things to come. So as I said earlier, I'm over the crisis call center. And what we have recently started doing is trying to get certified through Lifeline so that when 988 goes into effect, that we can already be on board and prepared for that. It's a very easy process. You go to their website and there's a link that you can click that says, get certified. So you get the application, there's lots of questions. And so I've spent time writing policy that reflects what Lifeline is expecting of us. A lot of it's things that we've already been doing, but we're also going to improve and start using the Columbia to do telephone assessments. We're going to get some new software, a platform called iCarol that will allow us to do chat, text, be able to keep data. It's very, very exciting because we were using a phone system that didn't have caller ID and just we would get the call, write it down on a piece of paper and hope that we got an outcome. So we're very excited to be able to gather better data to see what we can improve down the road. In addition to that, we are working on getting a crisis call line clinician in place so that when, and this is to fast forward, when Chaz talks about mobile crisis, our crisis call line clinician is going to be taking the calls, being able to do those risk assessments, ideally doing information and referral and assisting with resolving some crises that they can on the phone. And then if not, then they will be dispatching mobile crisis out to the scene. So that part for me is extremely exciting. The next part, as I had said, I'm going to push back over to Chaz and have him talk about our upcoming mobile crisis team and the planning that's gone into that.
Thank you, Marge. After we came to one of the crisis academies and they had discussed mobile crisis, we knew immediately that as a trauma-informed agency, and I say trauma-informed, and I look at that as a continuum. So we're constantly learning how to be trauma-informed. I knew that we wanted to shift into a mobile crisis model to meet our patients where they are in real time and reduce the amount of people that are going to emergency departments. We want to be, as clinicians, the first line of response for our patients so we can meet them in a trauma-informed way. And I can't express trauma-informed enough when it comes to mobile crisis. The model that we had looked at closely was the CAHOOTS model that was presented in one of our crisis academies, and I believe it was established in Eugene, Oregon. So we have been emailing them a lot back and forth to learn about CAHOOTS and how to implement it. So for the past 6 months, Marge and I have been working, Margaret Sterling, have been working with our local EMS department, the chief of EMS, and our local 911, and we have established MOUs. So over 6 months, we have developed a process to start implementing mobile crisis. We have our mobile crisis clinician hired, and he is currently on the Mobile Crisis Academy watching as we speak. We are going to pair with an EMS provider. We really wanted to stay away from law enforcement because we wanted our patients to see a clinician, to see a medical professional. We know that there will be times where we're not going to be able, out of safety reasons, to respond to certain situations, but the goal is to respond to all situations. So that's the model that we decided to go with, was Cahoots, to make sure that we had clinical staff on site. We have worked with several different hospitals in the Columbus area to be able to do direct admissions, and the EMS personnel is going to be the most vital piece of being able to bypass the ED and do direct admissions into these hospitals. We have developed a form, which we're still going back and forth about how this form is going to look. The state has something similar to this form that they're using with jails, where if they're within a certain age, their vitals are within a certain range, then we're good to move forward with direct admission. So that's what we're currently using. We really want to keep our community members out of the ER. So that's one of the main goals, and to be able to assess them in the community where they feel most comfortable. A lot of this will hinge on triage, because triage is going to be one of the most vital pieces of mobile crisis, and that's going to be where Marge's call center comes into play. So we're so excited to start this initiative. The goal is to have this started no later than the end of March or early April. We're going to rule this out. We're just piloting in Athens County right now, but the goal is within 6 months to add Hocking and Vinton. And then, of course, we're going to add Gaia, Jackson, and Meigs as well. I can't express enough how excited we are about this. Of course, Marge and I are used to going through trial and error and error and error. So I'm hopefully we can have a lot of trials in there, but we're going to learn as we go, and we're really excited.
Yeah, we absolutely are. And I forgot to mention when I was talking about the hotline that Gaia, Jackson, and Meigs also have their own crisis hotline right now. But once we are Lifeline certified and get the mobile crisis process going, and as Chaz said, do the trial and error and error and error and more trials that are positive, we will be planning to combine the two hotlines so that we can have a central dispatch location for the mobile crisis teams. So that's also very exciting. So when we're about a crisis continuum of care, a lot of them stop at mobile crisis, a lot of the models that we've looked at, but we look at our continuum as going farther than that. When an individual is pre-screened and they're not in need of hospitalization, they can be referred to the crisis stabilization unit, which Chaz's team does. They can also be linked with outpatient services. They can be linked with other community agencies. And Chaz has a crisis case manager that also can be utilized for follow-up and for linkage. The Zero Suicide Coordinator for Athens, Hocking, and Vinton also will make telephone contact and caring contacts farther down the road if the person is at risk but is not hospitalized. If the person is hospitalized, then they can be referred for placement at the Adam Amanda Mental Health Rehabilitation Center. And we are able, as I said earlier, to link people to a lot of different services through here. And I imagine that some people, because I think there was supposed to be a crisis academy that talked about that, but because of COVID or the weather or one of those two natural disaster things, it was canceled. But if there's questions about that, you guys can email me. And then I had already mentioned the Zero Suicide follow-up. So just to wrap up, what Chaz and I have found for a rural area for crisis mental health, the increased need of crisis down here, there's increased challenges. The most important thing is coordination. We are coordinating with hospitals, with law enforcement, with the jail, with different outpatient agencies. We spend a lot of time talking to people, keeping the lines of communication open so that if there is any issue or challenge, or we're getting negative feedback, that we can address it immediately. The second really important piece is training. Everybody that can be trained should be trained. which is why all of our crisis clinicians do shadowing with Chaz and his team until Chaz feels that they're capable of doing adequate pre-screens on their own. There's the training of the outpatient behavioral health staff on how to manage crisis and how to de-escalate a person that's in crisis. There's the training on the community level of CIT team training and advanced CIT and mental health first aid that is made available through our 317 board. And so there are a lot of different things that are available down here for training. And then the final most important thing that I think is essential for rural areas is ongoing relationship building. We can set things in place and set processes in place and hope that things will just go well across the board. But the reality of things is that there are things that are not going to go well. We'll have the errors that Chaz mentioned, and we have to be able to have comfortable conversations with our community partners to be able to resolve those so that we can work better and be able to provide better care for the individuals in our area. So with that, I'm putting up our contact information for Chaz and I. If there's any questions that you have that we don't get to today, feel free to email either one of us and we will get back to you as quickly as we can. And with that, I will pass things back to Alyssa.
Yes, we have a lot of questions. So if we can get to them all by noon, we will. If not, we will save those questions and maybe we could answer those in writing. So our first question is a doozy. It is, on your crisis stabilization units, how many residential staff do you have per client in shifts? And do you have separate staff that attend to your inpatient clients, or do your residential staff members cover both jobs?
So for all intents and purposes, we are in one building. So we don't separate the quote unquote inpatient clients from the community-based clients. Everyone is admitted the same way. They're in the same program. They're covered by the same staff. And so for each shift, we have 3 shifts. There's 8 to 4, 4 to midnight, and midnight to 8 a.m. We have at minimum 2 residential staff working at all times. There's always a backup supervisor, me, that they can call in case there's any issues or questions or concerns. And then they can also get a hold of the crisis pre-screener on call on Chaz's team. The clinical staff is here Monday through Friday. We kind of stagger our times in and out. So we generally have clinical staff here from 8 a.m. until about 6 p.m. Monday through Friday. And we're all fairly well cross-trained. So if there's somebody that's not available for residential staff, then one of us can step in and do those responsibilities. It's a whole lot of teamwork to keep the place going, but I think we do very well. And the only difference between the community admissions and the hospital admissions are how they get referred and then length of stay.
Thank you. The next question is, does your Adam and Amanda house accept patients 24/7?
We admit people Monday through Friday when clinical staff are here, because we like to start with, the referral starts at the time that the person is admitted to the hospital, and the referral information can be sent because we have to review that, and we do a telephone interview with the person to ensure that they're going to match up with the facility and be willing to participate. So there's a lot of background information that we get, and the clinical staff are the ones that can do admissions. So we will take referrals 24/7. We will take admissions Monday through Friday. We don't do private admissions on Friday because we have found that sometimes people don't get here until after 6, or the meds don't get into the pharmacy before the pharmacy closes, and we don't want to go into a weekend with a person not receiving their medication.
Thank you for that. There's another question about Adam and Amanda. What formula did you use to determine how many beds you needed? Our concern is about beds sitting empty. Did you have this issue, and are there times when an individual who was put in a bed would not have normally been recommended?
I don't know that it was exactly a formula for beds for how we figured out how many to have. Initially, before Adam Amanda was connected to our crisis unit, we had 8 beds, and we expanded to 16 when we added Adam Amanda. And that's because that is the amount of beds that we can have for a crisis stabilization unit through the state, for the type of license that we have. And with the coronavirus situation, we have had a really rough time trying to figure out how to do admissions from the community and still keep the individuals here, staff and clients, safe. So we have had a lot of empty beds at this point because we're not taking community admissions until we figure out a safe way to do that. If somebody needs to be in a bed, then if we're able, we take them. If there are people that we cannot manage or that don't want to be here in a voluntary facility that may leave, or if they're violent, we don't admit them.
Thank you. Another question is, how is your staffing increases funded? Is it Adam H funding or solely billable services?
For Adam Amanda?
Yes.
Okay. A lot of the financial piece comes from billable services. We don't charge a daily rate, but we do bill for the day treatment that is provided, the case management, the therapy, medication stuff. But there is also funding from the Adams Board.
Another question is, was it difficult to get ERs on board when giving the screening tool before calling?
No, it wasn't, because we have a really good working relationship with both of the hospitals that we are in. So when we sat down with them and said, this is a tool that we would like to be utilized, and this is why, and we showed them the data behind it, they were quick to adopt it and start administering.
A follow-up to that is, can you explain how the hospital liaison functions differently than the pre-screener? And are your after-hours pre-screeners in-house or on call? And the last piece of that is, can you speak to how you've addressed any challenges with staffing crisis services? And that will be our final question.
Okay. Our hospital liaison is different from a pre-screener because our hospital liaison only does hospital discharges. Because we do discharges from 3 counties, we have enough that we can have one person who is in constant contact with all of the private hospitals that we utilize, and the state hospitals. So his primary role is to link our patients with appointments for an intake, appointments for primary care providers, appointments for a psychiatric provider. And he also, our hospital liaison also does a bit of work over at Adam and Amanda and Respite. He'll run groups. He'll often run groups out in the community. If he has a slow day, which are very few and far in between, since we had about, I want to say 778 patients met criteria for inpatient hospitalization, so they keep Dan pretty busy. The pre-screeners just do assessments in the hospitals, the clinics, and the jail. So they're 2 very separate job descriptions. our pre-screeners are licensed clinicians, and then our hospital liaison's a case manager. The second part of that question was?
The second part is, can you speak to how you've addressed any challenges with staffing crisis services? And there was one final question, is your crisis services for youth or for just adults?
Our crisis services are for youth and adults. I will be honest with you, I have not had any problems staffing our crisis team here. But to be completely transparent, if there's ever a time where I do have a problem, I jump in and I do the pre-screens myself. I don't rule with there will be gaps in coverage. I don't believe there should ever be gaps in coverage in crisis services. So I will come in at any hour of the day and do it myself. And as far as night shift is concerned, as of right now, we have someone who they're on call. So they're not on site on night shift, but if they get called in, then they will come into the clinic and do pre-screens.
And as far as the crisis stabilization unit, Adam, Amanda, we serve 18 and older, but one of the things in Hopewell's future is that in the Gallia-Jackson Meigs area, Hopewell is looking to open a child crisis facility. So we don't have anything set in stone with that, and I can't speak too much to that, but I know it is in the works and in the plan.
I think we have a building.
Oh, more to hear on that. And thank you so much, Hopewell, for presenting. It's wonderful to hear the local perspective from providers here in Ohio, how their crisis systems are working, specifically in the rural areas. So we thank you for taking your time. We appreciate it. And I'm going to transition this over to Sherry Walters.
Thanks, Alicia. It's just going to take a second. First, let me thank Chaz and Margaret. We really appreciate your coming today and telling us about Hopewell and the Adam and Amanda Center. I also want to thank Camille and Ron again. I think you all had some great presenters today. Hopefully you enjoyed this Crisis Academy. I also want to very much thank Courtney Ebersol, who really did all the work and made all the arrangements today. And I want to thank Alicia for doing all of the moderating today. You will be receiving from Courtney your evaluations and a GIPRA. We're asking that you fill those out. If you hope to get CEUs, you must fill them out and return them before you get your CEUs. Once we get the evaluations and the GIPRAs back, Courtney will work on getting out the CEUs for today. Again, thank you so much. Stay tuned. We're going to be announcing, I believe we're having possibly one more Crisis Academy in the next couple of months. You'll be hearing more about that in the coming weeks. So thank you all for attending. We really appreciate, Courtney says at the end, we had over 400 people that registered. So this was one of our larger academies, and we really are happy you all could come. So thank you all for attending, and I hope you have a really good afternoon and the rest of the week. Thank you all so much. Bye-bye.
Thanks.